Okay, good morning everyone. We're just going to have to make a start for 9 o'clock because we've got a very full agenda. So welcome everyone to the first of hopefully of many AHP and cancer nursing conferences. So my name's Libby Crowther and I'm the lead cancer nurse manager at Kingston Hospital and the RMP lead cancer nurse, and my co-chairs are Lorna Smith, lead cancer nurse at Kingston Hospital and lung cancer CNS, lead CNS, and our AHP co-chair is Lucy Eldridge, professional lead for dietetics at the Royal Marsden. So just before we get started, I just want to say it's fantastic that we can all get here and make the time. I think there's some more people coming, so I've got about 100 people who have registered for the event. So people will be coming in, but it's great that we can meet, take the time out of work to meet face to face and do some networking and share this experience. And before we get started, I'm just going to go through some house rules. We do actually have a fire, we will hit a fire alarm at 11 a.m. That's a planned fire test. If there is an alarm outside of that then please head for the exits. Toilets are located just as you come down the stairs. I think most people have found them. There's a cloak room just near there, so if everyone leaves their cloaks around there. There are breaks throughout the day. There's a break in the morning and then in the afternoon and then an extended one for lunch. This is being filmed and there's going to be photos taken throughout the day, and we're encouraging everyone to tweet on the hashtag at the bottom of the screen. So if you really don't want to be photographed, let one of us know, and we will let the photographers know. So as I said, it's great that we can all get together and share the experience. So we've got a full agenda. This morning's is focusing on healthcare inequalities and patient experience, and these are pivotal to everything that we do. So what we really want you to take away after we hear from these speakers and after today is a better understanding of healthcare inequalities experienced by our patients and what the experience is like for patients. Also some tools and some knowledge that can help reduce these inequalities. In the afternoon, we're going to look more at opportunities that can support you in your cancer careers.
That's what we do. So what would we like you to tell us from today? So most of our speakers will be part of the World Cafe after break, so there won't be a question and answer session after the sessions this morning, apart from Sharon Ann Phillips, and Libby will facilitate this. But we do want to hear your thoughts after each session. So on the back of your delegate programme, there is a notes section. If you can make some notes at the end of each session so that you can share those thoughts and ideas in the World Cafe, that would be brilliant. Also, we've got a QR code up here for any feedback and suggestions that you might have throughout the day. And at the end of the day, we'll be putting up a feedback survey via a QR code. If you can complete that, we'd be so grateful, because we want to continue on from today with webinars, conferences, community of practice. And we would need your feedback to be able to shape these future events and shape them to what you want to get out of them. So we'd like to introduce our first speaker. So Lee Dibben and Stewart O'Callaghan from OUTpatients, the UK's only LGBTIQ+ cancer charity. Welcome.
My name is Stewart O'Callaghan. I'm founder and chief exec of OUTpatients. We'll do the proper talk in a minute. The person who's scrambling to fix our tech with the people is Lee. Give everyone a wave, Lee. There we go. We both use they, them as pronouns, just to let you know, and we are the UK's LGBT cancer charity. Some of you might have seen us present before, or maybe you've done projects with us before, so apologies if this is going to be a revision. But for those of you who haven't, we're just going to go through some of the basic stats and scene setting, and we'll be at one of the World Cafe tables later as well. So if you've got time for questions in this session, great. If we don't stress, you can come chat to us at the World Cafe. So, as I said, OUTpatients. So you might previously known us as Live Through This when we have bright purple branding. We decided to rebrand because we're growing, we're doing more work. We work both locally, nationally, and internationally. And we also wanted to be more inclusive of our palliative community as well. So we're doing the whole cancer spectrum, all the way from public health and screening, all the way through to living with and beyond and palliative. So like I said, this is an intro. This might be a refresher for some people. For some people, it might be new, so I will go at some pace, but again, you can quiz me later at the World Cafe. So we'll start with terms and language, because these are the core concepts you need to talk about our community. So as a charity, we use LGBTIQ+, and you might have previously just seen the LGBT, and that's fine, and that's usually the shorthand anyway. But we use this, as I said, because we work internationally, and this is the European Commission standards. So to break down all the people in our very broad community, you have LGB, which is sexual orientation, so that's your lesbian, gay, and bi. You have T, which refers to trans people, that's about gender identity. I is intersex, which is for people who have variations in their sex characteristics. Q is for queer, which might make some people feel uncomfortable, but it's a reclamation of a slur. And it's something that is very popular with younger cohorts because it's a bit more of an expansive, looser label for them to identify with. And you also have the plus for others. So this is a lot of other people who we don't stick in the LGBTIQ+, or else the letters would just go round and round and round and probably circle the room. So we have asexual, pansexual, demigender, and so on and so forth. So we'll start with sexual orientation, so that LGB part. So the important thing to note is that when you look at stats, you're going to be seeing them usually on a national average. So what that's doing is it's going to be effectively collapsing all age groups together, obviously. And what you're going to miss in that picture is that actually sexual orientation disclosure of being not straight is growing massively with each generation. The bit that's really interesting is the red bar, is that bisexuality is the most common disclosure that's going up. And this is something that we've noticed over time as well. So it's not just a very sudden thing. Over the last 5 years, there's been a steady increase in disclosure, which might give us the indication that we're living in a more tolerant society, etc. But it's interesting that bisexuality is the one that's disclosing at the highest rates. But some people won't be telling us this. You know, some people won't feel like it's their place to say, they feel safe to say, maybe it doesn't feel safe within their families to say. And this is why even on self-report measures where there's a level of privacy, you still have high prefer not to say rates about this question. So we really need to break down the stigma, but also understand the cultural lens of stigma that might exist as to why some people may choose to disclose this or not. So the same kind of things apply to talking about gender identity, so the people who may identify as trans. So same factor about a bias of age coming in. So as we look at this and we think about those younger age groups more likely to disclose, I would also give us pause to think, actually, potentially, these higher disclosure rates may also be in these older populations, but they do not, I feel, as safe to share that information. Or maybe even define themselves with the language. For example, I have personally known people who in this older category would identify their gender as butch, because that was the language at the time, but then in a remodeling of younger language, they actually sort of found their identity and described themselves as non-binary and butch. So although there are these new labels that keep popping up, actually these labels can just be other ways that we can explain existing experiences, but just obviously every generation likes to find their own language within that. So that's kind of who we are, but why are we talking about it? So medical mistrust is a really big problem in our community. So do people feel safe to go into healthcare? Do they actually trust the people that are looking after them? And we know about 45% of trans people and about 55% non-binary people don't really feel the GP gets them, is safe with them, understands their needs. And this is also true for intersex people who also say that their GPs don't really understand what's going on. And this is important when we talk about GPs, because they often are the doorway to most aspects of care, and they're usually the first and most frequent relationship someone has, which means that any negative experience there can start to really taint the way someone sees the rest of the pathway or system. So along with mistrust, you obviously get avoidance. So about 14% of our community avoid healthcare altogether. This can be higher in trans people, with about 27% of people saying they even avoid routine appointments like screening. And then 57% of trans people in a survey said that they would avoid healthcare even when unwell. And I know this to be true even in my friendship circles. I've known people in the height of the pandemic with severe symptoms avoiding A&E because they were afraid of how they would be treated. And it's important to note that anticipated discrimination can be just as powerful as active discrimination. And this is why it's really important that we reach first with our messaging to make sure that people understand we are welcome. We can't just assume people to test it and try. So, as I've talked about as well, it's this aspect of, unfortunately, one negative healthcare experience affecting the rest. And when you think about LGBT healthcare in general, it can be a pretty big postcode lottery about how well you're going to be treated, especially when you think about through different specialties. So even if you're doing the perfect job, someone before you may not have done. And here we have a quote from a focus group we did about screenings, and this person was basically saying that they know people who skip breast and cervical screening because of that really deep-seated fear. So again, it's that anticipated discrimination from a GP's office affecting the whole rest of the pathway. And I'm not saying then you all need to go away and start wagging your finger at the GPs, but it's that aspect of understanding that you still sometimes need to counteract somebody's previous negative experiences. So let's think about the cancer pathway. So I've talked a lot about GPs, and they're obviously just really the very front part, but there are aspects all through the pathway that affect our community. So this won't be a surprise to anyone, but obviously this is how the pathway works. So we're going to move all the way from sort of that public health and primary care part into the secondary, and then living with and beyond or palliative. So the first thing is that there's a lack of information directly for us. That's one of the reasons why the charity got started, because people were failing to see information that spoke to them, that represented them, that asked the questions that they were actually looking for. And this is how myths and misunderstandings actually permeate through the community. So there's a really, really common one about lesbian women not needing to have cervical screening. Obviously not true, but if you don't have the right information out there directly for that community, how is it supposed to be challenged? So this is how these things start to spread. And this means people aren't very aware of their eligibility, especially for trans people. When it comes to people who have re-registered their gender and they're not receiving automatic invitations anymore, are they informed enough to advocate for their screening as we expect them to? So it's all about not just the ability to be invited and informed, but also make informed choices. So this is why we do campaigns in this space. So this is one you may have seen. So we do have the successful Best on My Chest, which you might have seen, but we also have Remove the Doubt, which is in cervical. And this was done with West Yorkshire. And it was really important to us to get a variety of people. These are all LGBT people. They're real people. They're from the community, so that they could speak through their own experience in a campaign that also spoke to the community. So medical mistrust and avoidance obviously comes into screening, like I've touched on, but also we have this point about trans people in specialty screening appointments. So when people are thinking about avoiding healthcare, it can sometimes correlate with people who are trans men, people that are visibly trans, so sort of don't fit our expectation of a gender binary, and some levels of poverty or socioeconomic status can be relevant there too. Also, we know in healthcare, we don't really ask about SOGI. So SOGI means sexual orientation and gender identity. So we may have a sex marker on a record, but again, this is where problems come up with someone who's trans when they change that marker for their gender identity. We don't really have a good way of recording both someone's sex and their gender. And we're not asking things about sexual orientation, so we can understand not only how things might impact their care, but also who's relevant to that person, who's their support network, what other symptoms maybe have they noticed. Again, intersex patients are under-supported in this stuff. They lack the support, they lack the understanding from their medical professionals, and they often feel like they aren't being seen completely as a whole person. And I've touched slightly already, but systemic barriers. So a lot of this stuff, I think, when people talk about LGBT health, they think it's just a case of, well, let's be inclusive, let's stick a flag up, let's do these things, and that is part of it. But there's also some real systemic barriers. Even if you were being lovely and warm and wonderful, you still can't get a routine invitation sent out for a trans person for breast screening because it just doesn't exist. And the cervical screening one is still, who knows when it's coming. We keep hearing it's coming, but we had that for the last 5 years. So it's understanding that not only is it a difficult thing working in the thing for a patient, but also for yourselves. And I think that's why it's important to acknowledge it. So I've got a clip here, fingers crossed for sound, and this is Shah, and it really brings home the aspect of what it's like to be an LGBT person and that sort of avoidance of healthcare appointments.
When I found my lumps, I just ignored them for ages because I'm a lesbian, and like when we're doing our thing, it was uncomfortable to have like these boobs. Like it didn't feel like I was in my masculine energy. So I just avoided my boobs being touched. Yeah. And then when they were, noticing that there were lumps and there were pain, it was never something that I found out myself. It was always just, I'm making myself sound like a real stud here, but just that, the women that I was having my sexual experiences with, they would be the people who'd be like, oh, are you okay? Like, that doesn't feel right. But it took me a long time to actually get to the point where I was like, I'm going to go.
So a couple of things to take away from that is obviously someone's sexual identity is impactful in their decision making. They do feel like that's tied. Also, you have the point about the partners being the ones actually encouraging someone to go. So are the partners welcome in that space? Does it feel like somewhere where you can, again, get that additional history? Making sure that person and their support network are welcome. So when you get to the diagnosis stage, so again, trans status monitoring, it comes up as a problem. So thinking about effective referrals, people being set on the right pathways, especially if those pathways or tests that we need to order are considered sex specific. So if the person hasn't re-registered their gender, sometimes it can be hard to actually ask for those tests or make sure they're not refused at lab. Especially then also thinking about if you have a trans woman with prostate cancer and whether she has rearranged her gender on the GP record and how that's going to affect referrals and her support going through the system. So again, it's a systems-based thing, so it's not something that any individual person can unfortunately fix, but it's something maybe together we can all try and push for to be a change, and also create some expectation management in the patient as to which bits might get difficult and that you're definitely trying to do your best to support. Because the way the unfortunately trans patients' records do work at the moment, how it works is they go to the GP and say, I want to change my gender on the record, get an entirely new record, and then that clinical history gets pulled from one record to another. But during that, there is a possibility for the trans patient to actually include some of the records. They might say, actually, that bit's going to give away the fact I'm trans, I don't want that on the new record. It doesn't happen all the time, but it is an option available to them, and this can mean that their medical history might be incomplete as well. So you have to then think about that ability to build a rapport, get that information, and do it in a respectful way. There's also other aspects about gender-affirming care, whether it be surgical or medical, so prescription of hormones, and how this can affect our ways that we diagnose and support people, especially if we're relying on blood reference ranges or things like that. So if you think about, for example, prostate-specific antigen. And there's also a concept called trans broken arm syndrome. So it sounds really fancy, but basically all it is trans people often feel that they're going to have every aspect of their health reduced to their trans identity to the point where they could walk in with a broken arm and still be turned away because it's too complicated to do with being trans. So the point here is taking away the fact that absolutely treat the person as a whole, but also recognize when you are supporting an individual aspect or whether it does impact their trans-related health. That's not to say that them being trans as a person is not something to take into consideration in the consultation, but think about, for example, this person presenting with a headache, is it actually relevant to their transition, or am I getting a bit nervous because this might be getting more complicated for me, and actually it's not. When making decisions and supporting people, our community sometimes has different treatment-related goals, so the sort of scripts that we normally have in supporting people might not always work, especially when it comes to our bodies. There's also then these assumptions that we sort of creep into, so for example, everybody with breast cancer will potentially consider a reconstruction. Again, this might not be true for transmasculine people or non-binary people. And making space for that's really important, because if you make assumptions, you're effectively precluding their decisions and you're going to limit their autonomy and their ability to exist in that space. Some patients also might prioritize their transition over other medical care, which, especially in the case of cancer, might be a little bit confusing for us when we think about how serious often cancer is described, but this absolutely is the case in some people, and I've seen it firsthand, because for them, transition is also life-saving. So understanding the weight of the decision and potentially how long it's taken to get on transition-related care, if they've waited years and fought for that, and then all of a sudden it's going to be pulled away by something else, that can be a really difficult decision for them. And this is why clinics like OUTpatients exist. So this is run by one of our trustees. It's separate to us. It exists in the clinical space. And this is the UK Cancer and Transition Service. So we're not really expecting everyone to walk away after 15 minutes and be an expert. Definitely not. But these people are. These are the people that you can refer into, that you can make sure those patients are supported and get those very, very specific answers. So here's a clip about those difference in assumptions and body goals and how that feels for the individual when they're navigating that.
My name's Winter. I use they, them pronouns, and about 10 years ago, I had breast cancer. I experienced a lot of weird assumptions from the doctors about the way that my life played out, the types of treatment that I would want to consider, and they didn't have a lot of information for me about the treatments that I actually wanted. The information that they had was geared toward people who were choosing full breast reconstruction, for instance. What I wanted was a flat outcome, and this was pretty baffling to some of the doctors. What would have made the care better for me was just a team that was competent or had heard of my gender identity or my situation before.
Again, in that clip, what you have is the ability for the person to advocate for themselves. Is the primary thing, is understanding, again, there may be differences in goals, and it's not just when we think about tissue on the chest, it can also be in aspects like orchidectomy. If it's unilateral and it's a trans feminine people, I've seen them ask for a bilateral orchidectomy and trying to advocate for that to save them having to go for additional procedures later. So again, this is where that clinic like UCATS can be really, really useful. So when we get past decisions and we get into treatment, so this obviously then starts to lean into things like the CPERS, and we definitely see in the CPERS lots of aspects related to our community where people are having poor experiences, especially for bisexual people. But it's important to note that 23% of our community has seen discriminatory remarks by healthcare professionals. In one case, there was a trans person who had a wonderful consultation with the person who was leading their care, but the moment the person left the room, they started misgendering them to everybody else they could in the hallway. And that patient heard that. So again, you've built trust and absolutely destroyed it, not just in that one instance, but then in the faith of that person moving forwards. So it's being able to support people not just when they're in front of us, but also the whole way through their experience. Because 38% of trans people do report poor experiences and they believe it's related to their gender identity. So as I've touched on, the Cancer Patient Experience Survey year on year shows that our community has poorer experiences and there's not really much movement on it from a top-down level, which is why it's left to people in the third sector to really pull it up, and people like yourselves, hopefully, who believe in our mission. Psychosexual impacts are massively underaddressed as well. So we know this is the case really for every patient, but then when you add an LGBT element, it absolutely is the case when people want to start talking about anal sex, where they want to talk about other sexual practices that maybe they feel their clinicians aren't supportive of. And we've known patients who have directly asked their consultants for support and received none, and as a result had to go as far as America to get help. So these people are desperate, and if they're not supported, I've also known another patient who ended up falling into depression, losing a relationship, losing their job, and becoming socially isolated because no one would talk to them about the kind of sex they were having. So these simple things that you could be doing, or anyone could be doing, normalizing these conversations absolutely supports people. And that's where that affirming relationship can be really, really a lifeline. So here's Michael. Michael's the person I was talking about who went as far as America to get some answers, and you can see Michael's story right here.
I had an anoscopy, which is an examination using a camera. So my insides are being looked at by one of the physicians who was looking after me, who was utterly brilliant, I have to say. And I said to her that, no, I'm having problems with anal stenosis. It's a fairly common side effect of pelvic radiotherapy where the anus and the rectum just tighten. And she incredibly apologetically said to me, all I've got to help you is after visual aid time is this. And this is what she gave me. And like I say, she was extraordinarily apologetic about giving that to me as a way of me hoping to go back to having some form of sex life. It's still in the box. I've never used it. I wouldn't want to use it. It's, you know, how that equates to intimacy, I just don't know.
So you can see the difficulty there, right? And I mean, let's face it, no dilators are really that lovely, but it's that point about thinking of the patient, are they being supported? And yes, we are sometimes limited by the tools we have, but then how can we get creative? Can we suggest other alternatives, or at least can we support the person in their frustrations? So thinking about end of life then, so patients who get to this point, 74% of them who are LGBT don't feel that they're going to receive good end of life care, and this can sometimes be in relation to their wishes, their autonomy, like we said before, about how this might be different from other people. Also, if it comes into palliative care or hospice care, there's also a lot of fears around going into those environments, but also it's not just in the individual, it's their support network. So disenfranchised grief, so the fact that some person's grief might be taken less seriously than others, is a really big concern in our community because we have what's called chosen families. Sometimes they may not be biological families, they may be people that we have built as a support network around us, and that's the people who are important to us, and they should absolutely be seen with really important in our life, sometimes to the same level as biological families, sometimes more. But there is this aspect about also posthumously, will we be respected? This is a really big issue for trans people in understanding that they will be respected in death, and that comes down to legally their name and also their wishes. So really, really important stuff, and there's been a really good bit of work with hospice on this. But for those living with and beyond, I'm in this category. If anyone's heard me speak before, you'll know I have blood cancer. I've had it for about 6 years, and I lived with it and still do. It's incurable, so this is actually what led to the start of the charity. There was really nothing for me, and I kept asking around. The only thing available was prostate, and that's not what I had. So anybody who was sort of outside of that one support option had nothing. So this is why the charity got started, and that's why we create so many materials and come and speak and do all of these things, because I, like myself, like Michael, who you saw earlier, went and got a bunch of leaflets and left them in the corner of the room because they didn't really speak to our experiences. And this, unfortunately, is an issue, and we are one very, very small team. I mean, Lee and I are pretty much half the team, so, you know, very small. And this is us trying to change this postcode lottery of care. There are some centres of excellence. There are some people who are doing a great job, but if we all went away and did a great job, we could help to create that tide and that uniformity of care, because I know people, especially trans people, who will come all the way from Wales to London just to get their cervical screen because they know they'll be treated right. So think about the burden of that on top of going through an appointment, which may already be a difficult one. And this is where social prescribing could be really important, but a lot of social prescribers have sort of just been set up and left to it. There's no real backbone of resources for them. There's no credible network for them to get into and understand or find people like ourselves. So I think it's making sure social prescribers also don't just limit themselves to their immediate area or bias, also thinking above and beyond. So, I've whipped through that. You did say there would be a 2-minute card, but I looked this way the whole time, so very sorry if I missed it. But again, it was a whistle-stop tour. I'm not expecting everything to have landed perfectly, but that's why we'll be at the World Cafe if you want to come and explore anything in more detail. But thanks for your time.
Thank you so much, Lee and Stewart. That was amazing. I think it's really inspiring, and also you've definitely, for me, taken a lot of challenges and things that I can take back to my practice and look at again. I think it was really like showing Char's story. I hadn't thought about discrimination before you even walk into a healthcare setting. So that was, I think everyone would feel the same, that's made you think a lot about going back into your own practice and what you can not necessarily challenge, but you can see where there are blockages.
Absolutely, and I think that's also why campaigns and bits of work, so if you do after this think, actually I want to do a small project, make sure you involve the community, because then your message goes further, because it doesn't feel like it's sort of distinct or removed from the reality. You've got people who've actually been through it, and that's where, for example, our Best for My Chest campaign was great, because it's people who've been in screening, talking about screening, so the community could trust them, and then by extension trust the NHS.
Yeah. So, thank you very much.